legislature got to do this here. I got it. Okay. Uh, was a definitely a learning experience, and as I was initially given the early education, and the Veterans Committee, uh, I, I was looking forward to those, and had asked specifically to be on those committees. And all of a sudden, right before a session, I got a call and said, "Boomer, would you consider being on the behavioral health and mental health committee?" And I thought about it for a little bit, and it seemed to me that being on the behavioral health committee sort of encompassed the other three. And I felt like that was probably even more important than the other committees I was already on. I have a lot to learn, as I mentioned. It is amazing to me, and I want all of you to know how much I appreciate what you do. I had a visit with the supervisor at the Devereaux Center yesterday, and got to visit the little homeless shelter. Amazing place, an amazing woman that's there. So she told me about the circumstances of being almost overwhelmed by the need, and I think that's almost statewide, to be very honest. So whatever I can do to help you, to help your patients and clients, please don't hesitate to let me know, and I look forward to the conversation. Thank you.
Running two computers. So if you see me looking up, I've got a monitor behind my monitor. So we'll start running through, folks. And I had put first on the list to have Coos Health and Wellness's staff go, if you would.
Jamie, do you want to go first, or do you want me to go first?
Go first, Megan.
Oh, crap. Okay. So I think one of the biggest things that I know when Jamie and I had spoken with David as well is definitely the housing issue is our hugest is not a word, biggest barrier right now. And I mean, just the whole gamut of it, not only, for our clients, but for our homeless population, for our staff that are trying to move here, which, creates another problem with staff retention and the ability to bring staffing in to help, fuel access to services. If we don't have staff that can move here because there's no housing, it's really hard to expand our services. So that is definitely number one for us, is the housing issue, and being able to provide housing to our clients who are struggling. It's hard enough for them to come in and make their appointments. So can you imagine them being homeless and then trying to take medication, trying to get transportation to their appointment and things like that? So really, if we can look at a way to address housing, I think that would really help out the community and client needs as it relates to, the mental health barriers and some of the things they're facing out there. Jamie, did you want to piggyback on that at all?
Yeah, I do. I would say it's not even just housing. One of the things that we're fortunate we have some supported housing, but we could use a lot more. As Megan was saying, a lot of these clients need to be linked up to resources. They need support. They need somebody around just to remind them to take their medications. So I run the forensic team. So my clients have even more barriers on top of a mental illness. They have a criminal history. They have bad credit. They haven't had a job. Nobody wants to rent to them. They're sex offenders. Even a lot of the housing that we do have, they can't live there because of their sex offender status. So then they end up on the streets. They pose a significant issues for the community, for the police, for themselves. It's just this non-ending cycle that we're unable to really do anything about until we can get some help with our housing situation. Supported housing just helps clients meet a lot of needs that they're definitely not going to be able to meet on their own. Medication monitoring, symptom management, counseling. It'd be great if we could have some kind of a halfway house. And as Megan was saying, the other problem that we have is the state hospital, as we all know, is completely full. They haven't taken a civil commitment, I don't think, from anywhere in the state in almost 2 years. So a lot of those clients are very mentally ill and they're living on the streets, or they're staying in jail for long periods of time on wait lists to go to the state hospital, which is actually a violation of their civil rights. So it's become quite a problem for our state.
Yeah, I think also the other thing to bring up that we see as a need is like a crisis stabilization center or a place, where individuals in crisis can go to the hospital all the time, because we know that that's not always the appropriate place, but there's really, there's no in between at this point. I know there probably will be talk about a sobering center in a little bit. And so maybe, thinking about how we can join the two, where we can provide some support and some crisis stabilization along with, a sobering center, so that, our local law enforcement have a place to take individuals when they're not appropriate for Berea Hospital, emergency department, or appropriate for the psychiatric unit. They are doing that in other counties in the state with some success. And I think that that is definitely something our community could look at it as a benefit to those who are in crisis and just really need that level of support and can't get it.
Yeah, the other thing, which we also don't have probably statewide, I think in part due to the cuts in the funding, a lot of our adult foster care homes went away when the state cut the funding. I mean, there's just a direct link on the timeline there. Any rate, in our community, we have almost no adult foster care homes, especially for mental health beds. We used to have about 25 beds, and now we have like 4 or 5. It's extremely difficult, and the courts would like us to be able to serve members in our community. And we're really not able to do that due to the lack of foster homes, housing, supported housing. We are probably at least 30 units short on supported housing. So anyways, any kind of guidance or help or support we can get in that direction would be greatly appreciated. If clients can't meet their most basic of needs, just housing and food, they're not going to be able to do anything else until they accomplish that, sadly.
Miss Mooney and Ms. Riddle, would you introduce yourself? I see your names, but I'm not sure who you work for.
Sure, I'm Megan Wright. I work for Coos Health and Wellness. I run the mobile crisis team and also access to services.
Oh, great. Thank you.
I should have introduced myself. I apologize. I'm Jamila
problem.
Mooney. I run the forensic team, the older adult team, and I do quality assurance for Coos Health and Wellness. And we're filling in for David. He's off today doing something fun.
Good for him.
Yes, I'm glad he had the opportunity to have some fun.
Thank you.
Thank
If
you.
we can tack in 2 little clarifiers, it might also help for Boomer to define a forensic team and know what year that was that the state cut funding for the adult foster homes.
Well, that's a good question, Drew. I'm not sure I know the exact year they cut the funding. It may even been before I came to work for the county. I want to say it's been, I don't know. I'd have to find that year out, but it's been 5 years, maybe 10 years. It was I think it might've been since before I worked here. So the forensic team is an umbrella. We serve parole and probation clients in jail, clients who are 370, so who are unable to aid and assist in their own defense, clients under the psychiatric review board, clients who are on parole just coming out of either our state or another state or a federal prison, that whole group of clients.
Okay. Did we have anyone else from Coos Health and Wellness, or we'll move on to Advanced Health?
Nope, just us.
Okay, moving on to Advanced Health then.
All right, well, I'll get started, and then Joanne, I'll have you jump in. Again, Boomer, we've talked once before. My name is Ross Acker. I'm a professional counselor and now the Director of Care Coordination at Advanced Health. I was at Coos Health and Wellness for 10 years. really won't speak much more to the housing issue. They're spot on. It's always been an issue as long as I've been here. There's been a lack of housing for our clients. I was going to speak to the need for directing funds and services directly to the crisis services community. So that's like the mobile response team. That's the officers in the field, like Officer Babb, who are dealing with this on a daily basis. It could culminate into some kind of a center. It doesn't matter what you call it, a drop-in center, a sobering center, a crisis stabilization center, but it's a diversion. We've been talking about diversion used to be a bad word years ago, but it's a word that needs to be understood, that it's a diversion away from the jail, the street, the hospital, for some of these individuals who are really in the wrong place and they need to get access to services, and that would be the best place to do it. Is not necessarily at the traditional places where some of these individuals end up. It would be at a new center where they could be stabilized and they could be hooked up with a peer or a behavioral health specialist. I think, like Megan was saying, that's already occurring in other parts of the state. It needs to happen here as well. We just don't have, it's a hole in the puzzle of the crisis system. So my mind is focused on the crisis system and supporting that. We oversee, 25,000 Medicaid members at the CCO level, and Joanne can speak more to what she's seeing. She's my lead nurse, and she's been in the field for many, many years and can speak to what she's seeing at the hospital and for the need for the expansion of the Cold Bank Village. It's just the beginning because of all of the individuals who are medically fragile, have complex high medical needs, mental health needs, and are homeless. So Joanne, I don't know if you wanted to comment more on that.
Sure. Yeah. I'm Joanne Rutland with Advanced Health Care Coordination Team. My background is psychiatric and medical. Housing, yes, absolutely. Expanding crisis services, yes, absolutely. But one piece that needs to be considered in that is that the mentally ill population, including substance use disorders, are becoming more medically fragile. Over time, we are seeing more significant, complex medical needs as this population has been declining without having housing. So I visit the hospital frequently, seeing individuals on the medical floors, and you put together mental illness with alcohol abuse and liver failure and homelessness. And what do we do for that individual? We have individuals who are mentally ill and diabetic, individuals who have wounds on their legs, their feet, and are non-healing, and we have nowhere to put them. And that's where the Cold Bank Village is hopefully going to come in. We are hopefully going to be able to put 2 additional shelters there for medically fragile individuals coming out of hospital or medically fragile who have a need that's not requiring hospitalization, but could lead to hospitalization. So right now we're paying for motels, and that is extremely expensive when we have hospital discharges that cannot go to the street, but they have nowhere to go. It's a vicious circle with the mental illness, substance use, and medical. So any facilities that we have that are added really do need to have the ability to have some medical staffing to address the complex medical needs that are associated with severe mental illness. Yeah.
And one more comment from me, Boomer, is that the state at some point needs to really start investing in some kind of a program like the National Health Service Corps which used to be a very high attractor for bringing people here with student loans, for behavioral health specialists to rural areas, because otherwise you're just not going to have the staff to provide the services that are needed so desperately in this community. So some kind of state-sponsored retention program to bring individuals here to serve the community.
I agree. As I serve on the various committees, two things always come up, and that is housing and workforce. I mean, for every agency, every organization, there is that need right now. And along with the workforce, then there's that subhead of childcare. And so all of those are coming up. And then, of course, then we're dealing with the behavioral health issues as such, which fit in there also. So there's definitely a need for a concerted effort of a systematic way in which we deal with these individuals that need our help. And I think that's what the committee, I know, is trying to come up with. So are you all familiar with HB 2949 and what has happened at the legislature? If not, I'll get you that information through Jew and make sure you understand that that's a beginning. I will tell you that in mid-June, I was given the instructions that I was to come up with what the behavioral mental needs of this district are. I have 3 days, and having no contact with any of you because we just haven't had the opportunity to meet. I chatted with Drew and some other people and came up with a concept to just get us started with crisis centers, sobering centers, crisis teams, those types of things, and some housing. We're looking at an initial start of $60 million, and that's just for our district. So the state's going to have to cough up some major money to be able to do this. And so I think what has to happen as we discuss this today, that we look at a systematic process of what we need to do from the time we meet the individual, or even prevention when we start, and how that ends at the state hospital if necessary. But there's a whole bunch of things in between we need to look at. So I appreciate this session, and hopefully from this I can get some help coming down our way. So I'll shut up and listen.
Thank you, Boomer. Did we have anybody else from Advanced Health, or do we want to move on to Coos Bay's Police Department?
Let's move on, Drew.
Yep, looks like we're either Chris or Officer Babb, whichever you'd like to do.
I can start it, and then I'm definitely going to want Officer Babb to chime in. My name's Chris Chapman. I'm the Chief of Police at Coos Bay Police Department. Sorry, I don't have any video. You just have my audio at this time. So, I think probably at the end of this listening session, we're going to all sound kind of like a broken record, because I think we're all going to hit on a lot of the same topics and issues that we see in our community or statewide. But Officer Babb and myself, we did meet up yesterday. We discussed, we put some bullet points together, and I'll just highlight on those, and then he can maybe drill down a little bit deeper into them. But really what we see here is, we've already discussed it, but there's a major lack of space at the state mental hospitals, which puts most of the burden back on the individual communities. And our community, we obviously have a lack of resources to fill those gaps from the state level resources, which really causes daily contacts with mental health patients. And we really feel like our contacts really oftentimes, or I would say probably 99% of the time, they feel like they don't have any resolution. Resolution because oftentimes there's really no place to take them. There's no place to put them. There's no additional services within our community to connect them to. And so we feel oftentimes like it is a revolving door. Some of the things that we used to do in the past, like we would maybe put what we call a POH that is a police officer's hold on some of the people that are having mental health crises at the time. That has turned to where it's such an extremely high criteria for law enforcement to do that oftentimes they don't meet the threshold. And now, even if we do and we are able to transport to let's say the hospital for or a medical facility for an evaluation, our police officers hold now really only gives us that authority to transport to that medical facility for that evaluation, and that's it. It no longer has any hold on it, no longer has any teeth in it. And so we transport oftentimes to a medical facility, and they are limited in their resources and ability to deal with the person that we're bringing in. And again, they're limited resources, limited space, because they're dealing with all the patients that should be maybe up at the state hospital, but there's no room at the state hospital. And so oftentimes our evaluations are actually happening even in the parking lots, and they're not ever even able to get into a medical facility that happens in the parking lots. And then that subject oftentimes is released out of the parking lot, and with really no additional like services or again, resolution. And there's limited spots at the hospital. There's limited spots. Oftentimes they don't meet the criteria to go to jail. Not suggesting jail is even the best place for them, but oftentimes you have basically a choice of either they've committed a crime, so we can maybe take them to jail, and that will maybe house them for maybe overnight, maybe oftentimes not even a 24-hour stay. But again, there's no resolution to the problem. They're released either from jail or from the hospital, only to basically have their mental health episode again. We would, from a law enforcement standpoint, we would greatly support some type of I've heard it referred to so many different terminologies, but a sobering center, a detox center, just an additional center within our community that would allow us to be able to transport them to not a hospital if they don't need immediate medical attention, and not a jail, or not to where we're having to wait for them to commit the next crime in order for us to get them housed in the jail and then sit in the jail for an extended period of time waiting for a commitment hearing. I don't think that is really beneficial to anybody. And then, if and when they do get released or they get sent to the medical or the state hospital, what we're seeing too is those that are being released from the medical or the state hospital, there's no real wraparound services once they're released. And so I say this, there's really nothing out there to keep them on track, to make sure that they are properly medicating, to make sure that they're meeting with their counselors and whatnot. And so it seems like this vicious cycle just starts all over again. And so that's kind of maybe a 20,000 foot view. Officer Babb, if you would like to speak to a little bit more of what you deal with daily, I think that'll help out.
So, mostly I would probably reiterate a lot of what's already been said. This isn't one issue. This is a combination of issues, and it is people are caught in this vicious cycle. One of the biggest issues for us on the street on a daily basis is we come across people that might be in mental health crisis. And I'm talking about some that are psychotic to the state that they have no basis in what reality is. However, they don't meet the very high threshold in Oregon of being an imminent threat of serious physical injury or death to themselves or another person. And they don't meet the standard of inability to care for themselves. And so they just continue on living in the woods or living on the sidewalk. And these are not the folks that are going to come into Coos Health and Wellness and make an appointment or keep an appointment. When you try to talk with them and say, do you want to get some help? They're so psychotic, they can't give you a real answer. But because they're not an imminent threat to themselves, then there's nothing you can do with them. And so oftentimes these people continue to degrade to a point where for inability to care, what I was told is they have to be 1 to 2 days away from death in order for them to be taken against their will. And so for us in law enforcement, even if we have a crisis center, which we desperately need, we have to have a legal way to move somebody from one place to another in order for them to get help. And so the ones that are unable to consent but don't meet that very high threshold of being in imminent danger to themselves, there's no legal way for us to get them help, which makes it really frustrating. And the public is very frustrated because a lot of these folks are on the sidewalk outside of businesses, and businesses call and say, people aren't coming into my business because these people are laying on the sidewalk and they don't want to go in there. Well, we don't have a legal reason or authority to get them the help. And so we see people living in just horrible, horrible conditions because their mental state has deteriorated to the point where I don't know how to explain it without showing it to you, but they're living, I hate to say it, but they're living worse than animals. I mean, in their own filth and bugs and disease. And you can't help them because they literally cannot give a logical response, a reasonable response. They don't even know where they are, but they don't reach that super high threshold in order for us to get them help. And the short amount of times that they do, say they walk out in the street in front of traffic, which is one of the things that happens on a regular basis. That's very fleeting. I can say, well, he's an imminent threat to himself because he's walking out in traffic. But by the time I get him in a car and get him up to the hospital, he's no longer walking out in traffic. So he doesn't meet that threshold again. So he's released, and then the whole cycle starts over again. So what I'm talking about, Mr. Wright, is possibly a change in the legislation in Oregon to give us the authority to help people that are in a psychotic state to the point that they don't know where they are. And I know that there's other states that are able to do this. California, I'll say, and I know that because we have a transplant officer from California, and their ability to help people that are in a psychotic state is much better in California than it is in Oregon. But then it leads into the next problem. We have to have a place to put them. We have to have some place to take them for the help. So in addition to everything that was already talked about, I think that we need some of that legislative change in order to allow us the legal authority to get people help that don't have the mental capacity to ask for it or even make a decision on their own health.
Much appreciated. Boomer, did you have questions on that one?
Well, I had no idea about the law that does not allow you to help these people. It seems like a lot of laws just get in the way of trying to help people, which is just simply amazing to me on a daily basis. Thank you for that, officer and chief. I appreciate that. That is definitely something I will take to heart, and I will get back in touch with you and see if we can come up with some type of a language. I'll look up the California code, and I will get back to you and see if we can come up with some legislation that I can submit to be able to help there. You bet.
In California, they call it the 5150 is what they call it in California. And I don't know if that refers exactly to a specific bill or a specific law, but that's what it's referred to as is 5150.
Okay.
I believe that's the penal code,
Penal code?
5150. So yes. And we just appreciate this listening session, and we are always available or make ourselves available to further this discussion. I think it's a extremely important topic. So thank you.
Before I head off to the next person on this, Mr. Wright, The other seat in my car is always open. So if you want to come out and ride with me and see what I'm seeing, you're welcome anytime.
You're on mute, sir. Okay. Well, next on the list, I had Confederated Tribes, but I'm not sure we have anyone from there on here. I know they're very busy. They just lost some of their staff. So we can, well, in CLCM, I don't think we have anyone here from Community Living Case Management either, do we? Nobody claiming it. So Columbia Care. I think we have somebody from Columbia Care. Yep, Jeremiah.
Yes, hello. So I am Jeremiah. I am the assistant administrator here at Cedar Bay, which is a residential home here in Coos County for Columbia Care Services. I'm definitely hearing a lot, the word, the phrase broken record has been thrown around. Absolutely. A lot of these services we provide, we're a private nonprofit, and trying to provide services to residents has been very difficult, just with the mostly coordination of care with state services. One of our biggest boons, and I want to tip my hat off to Mrs. Mooney and them at Coos Health and Wellness, phenomenal community partners. They've been one of our biggest assets in providing services for residents. But when it comes to working with, say, Social Security, APD, and mainly also CCOs, has been very difficult. It's mostly just to give you a rundown on my day-to-day activities, I could spend about an hour to 2 hours on a phone call waiting to get a hold of a representative for, like, say, Social Security. And I have to perform what is essentially mental health triage of services when it comes to what is more valuable in the moment for a client. Do I get them their money, or do I get them their insurance? It's difference between food and medicine. I can tell from experience, just this year alone, it took us about almost 8 months to finally get a resident their Social Security. They went essentially 8 months without funds. They backlogged. That's fine, they got it backlogged, but 8 months without money, for some, for most people, I'd say probably everybody, even in this call, going 8 months without money, you're going to be destitute. You'll be out, as Officer Babb was saying, you'd be out in the woods on the side of the street in no time if you had no money for 8 months. CCO, so a big concern we have when we get clients that transfer from the state hospital or from another county into our facility, when they come into our facility, we have to change their CCO. Usually that involves me contacting Coos Health and Wellness or community partners to try and get that switched. That can take months to several months. And CCO, by the way, is the Coordinated Care Organization. Every county has a different CCO. Ours is Advanced Health. But if you have somebody coming up from, say, Multnomah County into Coos County, they have to have their CCO changed before they'd be provided services. We, of course, will continue to provide services, but getting them a hold of their medication through pharmacies, through things like that, it can be teeth pulling sometimes to get these services to our residents. The biggest impact, obviously, and probably for everybody here, is COVID. We do have a crisis facility within Columbia Care Services within Coos County. However, it's a 6-bed facility, but 2 of those beds have been cut due to them being communal beds. There's 2 rooms that have 2 beds in those rooms. COVID has made it to where only 1 of those beds is currently accessible in each of those rooms. So 6 beds turns into 4. That's 1/3 of our crisis facility beds that have been cut just due to this. If we had a bigger facility or access to more rooms, that wouldn't be an issue. That would be dissolved immediately. Services have been exasperated immensely when it comes to just the coordination of care with other agencies. It is very difficult, like I said, several months a lot of times to make sure just even something as simple as getting their monthly Social Security check takes several months. Josh, did you want to add anything?
Sure, I'll go ahead and add a couple of things. I'm Josh Ferreira. I'm the residential director for Columbia Care Services for Southern Oregon and the coast. As Jeremiah mentioned, we have several different programs on the coast and here in Southern Oregon as well too, including residential programs and crisis programs. And I think he touched on it a little bit too, is where we're seeing a lot of challenges is navigating the extremely complex systems that are out there and available for resources for these clients to access resources. Just for an update for Jeremiah, we are back up to 6 beds for the CCRC, so we do have that available. One of the challenges we face, and this is a little bit of a trickle down effect, and I think Jamie and some others touched on this as well too, is that when the resources like at the state hospital, where they've had a moratorium on civil commitment beds for over 2 years now, I believe it's been since they've had a civil commitment admission, that trickle down effect ends up going to the hospitals and then eventually to the program levels as well. And we end up with the biggest challenge is not having the right resource for somebody. So for instance, the crisis center, CCRC, that we run, a lot of the times we'll get referrals for people who have a housing issue or would be better served with a sobering center or a detox center. And unfortunately, that's not something we can provide in a mental health crisis center. But what it runs into is there's just no place for some of these folks. And we end up seeing the people who slip through the cracks. And I think Officer Babb mentioned that as well. These are the people that we see on the side of the street who have gone on and lived in the woods, but we can't do anything for it because the resources are just not available for them there. And I think the more resources, including like something like a sobering center or something that would be more scaled towards navigating, again, the extremely complex systems that are available for housing and finding more housing options would be a huge boon for not only this area, but for throughout Oregon and throughout the country, in fact. But we're seeing some of the models that have been implemented in other counties, in particular Lane County with the Cahoots model, and a little bit more efforts to engage. And I know that there is a mobile crisis engagement in Coos, but more efforts and more funding for programs like that, I think would be instrumental as well.
When I had the opportunity to start chatting with people about this and make my recommendations to the state concerning the needs of the South Coast, I did contact with Florence, which is part of my district, and they're trying to organize a crisis team there too. They need they need a vehicle and probably some more personnel to be able to do that. But at least the plan is there. So hopefully we can get them some help and through my understanding, though I haven't met anybody from there, Officer Babb, that there is a crisis team in Coos County at this point that helps you, or am I wrong?
There is a crisis team that comes out and they are great. We work with them on almost a daily basis. But the biggest issue we run into with the crisis team is they're under the same criteria we are. They can't put a director's hold on someone unless they meet that really, really high criteria, or if they volunteer, they consent to go. And then we run into the next problem of, okay, we have someone that we can help. Where do we take them? So it's a complicated issue. We need the crisis center and we need to be able to take folks that can't consent or won't consent, that don't meet that high standard. So the crisis team is fabulous, but they're, again, under that same restriction or same high standard that we're under.
Mr. Wright, I'm the one who runs the mobile crisis team in the county. And so it's exactly what Officer Babb is talking about. Also, just having resources. I mean, we don't have a ginormous team either, and we've been short staffed lately. So, any help or boost there is always appreciated, because there are definitely some areas I think that we'd like to expand in that we're just not able to at this point.
I understand.
Any further questions, or do we want to keep moving? I think the Last I had on the list was Barry Hospital, and we've got quite a few folks from there, I believe.
I'll kick it off. Hi, Mr. Wright. I'm Kira Hood. I am the psychiatric nurse manager here at Bay Area Hospital. I've been here for 24 years. I work with all the departments in the house with everything related to psych. Recently, I've just accepted a director of behavioral health position at Advanced Health. And when I was talking about leaving my job of 24 years that I love, it was please give me the opportunity and the chance to work on a sobering/crisis center. So that has been my goal for years and years with Ross Acker. We've been dreaming about this forever. So I agree with everything everyone else has said. I'm going to take it a little bit. You're not going to find a more dedicated group of amazing people like the Officer Babb and what Coos, what our police officers have done with CIT training is incredible. They are so trauma informed, and we just really love our relationship and watching them work with our mentally ill population. The mobile crisis response team is incredible. I really think you've got the right people here to do really great things down here on the Southern Oregon coast. So I really look forward to working with you. I'm going to tackle a couple more issues about the laws, and I'd like to explain, you know, the difference between civil commitments and aid and assist, right? The civil commitments are serious and persistent mental illness people that don't have a criminal background. They're the ones that end up at Bay Area Hospital for long periods of time now that the state hospital is closed. I'll give you an example of what that looks like for us. We've become kind of the mini state hospital. We have had patients on the unit for upwards of 9 months. They've ran through one 6-month period, and we've had to recommit for an additional length of time. In that period of time, we had one particular individual that injured 11 patients and staff. One has never been able to return to work for over a year. And so while I agree with everything everyone else is saying, I really, really would like to put a plug to protect our healthcare providers and workers. And from what I see, you've got amazing staff that are trying to do the work of the state hospital without the resources of the state hospital. And we're really, the violence has exploded. And a lot of that has to do with the jail not taking COVID patients. It has to do with lack of resources in the state. It has to do with telehealth not meeting the needs of some of these folks we're talking about that are living in the woods. They don't have cell phones. They have a hard time making their appointments. So the violence has really become a serious problem. And we have ED staff that are leaving their positions, and APU psychiatric staff that are leaving their positions because you're bound at any given time anymore to get completely like lit up and punched in the face and being off on a medical leave. And it's not, and so what I really would like to propose is that we look at in doing what other states, make it a felony to assault healthcare providers. That's one of my big requests. I think that your healthcare providers would feel very supported if Oregon went with that. What happens now is we get punched in the face in the ED or APU or ICU, and we get to write a report. There's nothing that the officers can do at this time. There is no teeth that it's called a misdemeanor. To get somebody out of the hospital after they've assaulted somebody, however badly, to get them out, they would have had to use a violent object. Fists aren't considered a violent object, so they have to be able to use a weapon, and so we're stuck with some really, really tough individuals. I also, the 5150 inability to care for self, that is heartbreaking for all care providers. We watch these people come in, and they're very correct in saying that unless they're in imminent danger of harming themselves or somebody else in the next immediate future, Oregon does not look at that as a holdable condition. And so I can only imagine what Officer Babb sees out there. And the inability to be able to step in and help people in that situation is horrific. It's horrific for us to have to discharge somebody from our hospital because they haven't met that criteria. It's hard on everyone. Certainly hard on the businesses. I mean, all around, and people don't understand that we don't have a 5150. And so it looks like we're just kind of like turning away, like we don't do the hard stuff. We would love to do the hard stuff and get these people help sooner. Another thing I'd like to say is, when you're looking at the laws for violence, you can start mental health treatment in the womb. And if you started taking care of being a little tougher on individuals that are domestically violent, child abuse, the reason we have such horrific amounts of mental illness anymore is because we've gotten really lax on the abusers. And I can tell you stories where, children are coming in bruised from stem to stern, and it's a slap on the hand for the or the perpetrator. Is that the right word? I'm not very legal. We've got to look at cleaning some of that stuff up and protecting our women and children, because that's causing a lot of damage. I'll stop and let Larry speak, or somebody else from the hospital.
I could go unless Larry, you'd like to.
Oh, I think you clinicians that are on the front line should be doing the speaking today. Thank you.
All right. Oh, well, thanks for being here, Mr. Wright. I just want to make sure everybody can hear me. All right. Yeah. So my name is Bryson, and I'm the medical director for the emergency department at Bay Area Hospital. I've been an ER physician for about 12 years. So I'll kind of echo what was said in here, but I'll sort of limit this down to maybe what we see in the ER. So generally, the people who go into emergency medicine really do earnestly want to take care of people. As trite as it may sound, that's why we go in there. Now, mental health is kind of a complex thing. We actually can't really do a whole lot for mental health in the ER. We primarily focus on triaging people, figuring out who can go home, who needs to be admitted to the hospital, and sort of what's in between. Now, that's something that we always have seen within the ER, but it certainly has become much more prominent within the ER. We have had days where I kid you not, 50% of the patients in my emergency department are mental health related. And 5, 6, 10 years ago, it was never more than 10%. Many problems with this, of course. One is that we've got just so many patients needing so much mental health evaluations, we just don't know what to do about it. Typically as well, this very much sucks up staffing. A lot of these people who are suicidal, hostile, need sitters. So you need somebody actively sitting in front of them, watching them. So suddenly we lose a nurse or a tech to perform this function. So in regards to increasing cases, we've also had, as mentioned, these increasingly violent cases, which have become much more pronounced. I can say in my 12 years in emergency departments, it's never been this bad, ever. And the problem is, the moment one of these patients comes in, you can hear just this giant sucking sound as all the resources go piling down into one room to manage this one individual. And then, as I think others have pointed out, we can't take care of the strokes or the heart attacks because we've got some patient who is so psychotic and wild, we just have no choice. In regards to that as well, Kira pointed out the violence towards healthcare personnel. I've never seen it before like this. Many cases where staff members are assaulted in the ER. In many cases where these individuals walk free and then they commit a serious crime not shortly thereafter. I know one individual who assaulted a staff member here was discharged because there was nothing we could do about them, and I think they literally stabbed someone a few days later. And then they were, I think, felony hold and finally taken to jail. Maybe personally, I'll say, again, this is the worst I've ever seen it. And I've worked in big hospitals in big cities. My previous deployment, I'll say, was a community hospital outside of Seattle, which had no paucity of drugs and violence. But maybe I'm going to turn my screen here So this screen, this TV here is actually cameras and motion sensors that I've installed around my house. Maybe I'm just getting paranoid and weird with old age. Maybe I'm just a weird Oregon guy who doesn't, I'm the only Oregon guy who doesn't own a gun. But I am actually afraid because the people we are sending out of my ER are frightening. They're on the razor's edge of doing something terrible. And like Officer Babb pointed out, they haven't met this threshold for us to do anything. So I cannot tell you how many times we've watched these patients walk out of the ER and just cross our fingers that we don't hear in the next 24 hours they've gone out and killed someone, killed themselves, burned down a business. And again, 12 years, I've never felt this. I've never seen this. I've never thought about putting cameras up in my home, but that's where we are today in Coos Bay. I think that's really all I had to say. Larry, you want to?
I will sum up a little bit. Of course, from the administrative point of view, our job is to protect both of these people you've been talking to and, excuse me, help them be effective in their job and also make sure that our institution survives. And we are putting these people in a setting that is way more expensive than they need to be in. That's number one. And it's not appropriate for them to be there. And I don't want to be overly dramatic, but in today's world of COVID, it could literally come down to patients we don't treat die because we've got these people in the wrong places. And I know that sounds dramatic as heck, but I had to listen to people talk about it down at Asante Rogue in Medford just yesterday. So it's a problem that we're not uncharitable. Obviously, we're treating as many of these as we can. But as an administrator, I can't protect Dr. Inman and the rest of his staff. I don't feel that Kara should have to go down and fight somebody with a knife. You know, and it literally comes down to that. And so then we end up losing people, and it becomes hard to staff. We're sort of at the receiving end of a lot of this, I think. So, and I don't mean to make this about money. That's not really it. It's about where's an appropriate setting to treat these people. And it's not the hospital. I'm done. Thank you. Thank you for the time.
One more thing, Mr. Wright, is the psychiatric child needs have exploded. And I know I kind of mentioned that before, but we don't have anything in our local area for like a subacute, a respite, a place for kids to go for a couple days to sort things out. They come into our ED, which is a horrendous location to put any child for any length of time, and they'll spend several days up to a week while we try to figure out they really need a higher level of care, and there's no level of care higher that's going to accept they're all full and there's nowhere to send them. And so we patch together like the best treatment safety plans we can and look towards putting them right back into the situations and settings for lack of anything better. It's horrific for any child. It's horrific on the families. We need some subacute and treatment facilities for children with mental health issues. It's not just the OHP population. There's so many individuals with, let's say, our Bay Area hospital has great insurance, right? And if you have insurance, you're in a worse spot to receive mental health care for your child than you are if you are homeless, jobless, and on OHP. There are so many more services that you can actually get when you have OHP than if you work. You've got parents that are trying to work and have insurance, and that's something that I find very disappointing in our area. We have to send kids to Medford, to Eugene, to Florence for psychiatric care. We could do better. We can do better with our kids.
If we have nobody else from the hospital, I think that runs us through the list of everybody. And Boomer, if you have questions or want to learn more about any of these subjects, I'd like to open the floor up, or if anybody has more to add. We've gotten through
Well,
the.
I would, Drew, I'd really appreciate when this is all done, when you're doing you're doing your notes, if I could have contact information for all these people so that, you know, I could, when I have a question, I could just give you a call and or send you an email and just go from there. I tend to be a visual person. So as we end this meeting, what I'm going to do is sit down and see, and I know this is terrible, but to do a flow chart, which says from contact to state hospital, what do we need? What are the services that we need at each level as we move forward? So that I can then, as we move forward with legislation, I will tell you this. I'm only allowed two pieces of legislation in the next session, which comes up in January. So we may be looking at a little bit in trying to refine what we need and how we move from there. I don't know if you've received information concerning what they call from Behavioral Health Committee, which is called Behavioral Health Transformation. And basically what they're talking about is plugging in services. Representative Nose and I'm sorry, I forgot the senator's name, who've been working on this, basically start out with prevention and then of course housing and placement, what we need to do. But you know, as we're looking at that housing placement thing, I think that's where things like what Officer Babb were talking about and saying, okay, how these people need housing, but with the laws that are there, we can't get them there. So that may be a first step that we have to do. And there may be some other things, for instance, making sure, as Kara mentioned, that we get some help for the kids. You know, that's something I hadn't thought about. Even though I'm an educator, I spent 31 years in education. That's kind of my background. So I think that's vitally important. So I need your help with that. The more information you can give me as far as, okay, we take from step one to step hospital, state hospital, where do you fit in that? What do you need? And then I can look at that and start working with all of you about how we incrementally get there. Here's my big concern, and maybe it's just me, this is my opinion. The state right now has a whole pot full of money from the federal government. And so they're going to come down and give us money. And part of that money is offsets money that will go now to behavioral health. And there are some bills out there, and if you add them all together, there's about $500 million going to be available soon to help dealing with the mental health issues in Oregon. But here's my concern. Whatever we do as we think about things down the road, with your help, we need to make it sustainable. It can't be just a fly in the ointment type thing and said, well, we're going to fix it by doing this, because the state only has so much money, and we need to make sure that this is the core thing we need to work on. And I think it is, without a shadow of a doubt. So I need you to help me do that so that when I go to the legislature, I can say, here's what we need to do. Here are the steps we need to go through. And this is then I can look at it and say, okay, we need to allot this much money here, and money here. And if I have those specifics, then it's going to go a lot easier in making sure that we get help. And you all are involved in this process, and you know what we need. And I'm really taken back today. Thank you. We need a lot of services for people, and I want to help do that, but I'll need your help. So as we move forward, I'm going to kind of coordinate things with Drew and he'll kind of be my clearinghouse to be in contact with you specifically and help me organize. And I'll give him the information I already have, and then we can go from there.
Can I ask Drew a question, that something that might be helpful? Drew, do you have a copy of the housing study that was done a couple of years ago, where the major finding was that we retrofit our existing buildings to create
Yeah.
more?
I believe that was the CZB study. I do have that, and
I was just
quite
thinking
a
that
few
might
other
be-
studies.
That might be helpful for Mr. Wright.
Okay.
I would appreciate that. Thank you. The more information you can give me, the better off I can react in my committees, and make sure people have the other information, and then I can distribute that information to others in the committee that may or may not have it. So thank you.
And I'm also pretty sure it's Senator Wyden who's doing all the work on the mental health bills in Oregon, because he sends me emails all the time.
Good. I was thinking of the state senator, and it's a hyphenated word, and I cannot think of her name right now, but she's really involved in this, and they've done a lot of work. So I'll be working off of their work and see if we can refine it down to what Coos County and this district needs.
All right. I was just checking to make sure I've got the things I talked about. So that kind of brings us through it. Did anybody have thoughts towards the end? We've made it through the first hour. We've gotten everybody to speak, and now I think it's whatever folks would like to mill on or expand on that's been discussed.
One thing I'd like to throw out to just give an idea of the expanse of the issue that we have down here. And anybody that has newer numbers, please correct me. I understand the last time in point in time count for the homeless in the Coos County area was approximately 800. To give you, Mr. Wright, an idea how much that is approximately the same amount that's in the Medford area. So with our much limited resources that we have here in Coos County, we're trying to work with an exceedingly high amount of the homeless in this area, many of whom have substance abuse and mental health problems. So I just want you to understand that I know that you said earlier it's an Oregon problem. It's exceedingly a problem down here in Coos County.
How many would you estimate? How many veterans are involved in that?
I can make a little info on that number. About 2 years ago, the point in time count was 1,400 homeless individuals. I don't know if they ran one last year. It would probably been affected by COVID and drawn down the number.
Are you talking about Oregon or just Coos County?
Coos County, 1,400 individuals who are homeless.
I
Could
think
be
we have
800 unhoused.
We have a very high percentage of homeless veterans here, and a very small clinic that's maxed out in terms of providing resources to them.
Yeah, and talking to Patrick Wright, you might have already met him from Operation
Yeah.
Rebuild Hope. I don't know where he got the number, but he estimated 1 in 3 homeless individuals in Coos County was a vet. So in excess of 400.
Okay. Well, you give me a lot to think about. If you think of anything further, get a hold of Drew. I'll give you my email first off. Right, you can write it down. It's Boomer, just like my name, and I don't need to go into why I got that name, but I have a little hearing problem and I tend to talk loud. But anyway, it's Boomer, and then you add Susan to it, my wife's name, Boomer Susan at msn.com. And don't hesitate to drop me a line, and you could go to my rep mail, but I get 200 or 300 emails a day, and it's really hard to keep up. So give me that, and then I'll get back to you. If you have any thoughts, any suggestions, any ideas, ship them my way, so that I can correlate all this in mind. And I'll get back to you, and I'll try to put you on a little group and then send you all information about what I'm doing and how I'm doing it, and ask for help, and you can give me information there, and we can go from there. Officer Babb, I will take you up on that. I'm not sure when, but I'll give you chief a call, or you a call, and let you know that I would like to come down and take a ride. I've done that up in Florence, but that's been many years ago when I was a middle school principal. So I would look forward to that. Other than that, I hope to be able to come and visit each of you down the road, and just have maybe a one-on-one, and talk a little further about what's going on with you, and have a good look for myself about what you're doing and how you're doing it, and what your organization's all about. I hope you'll be able to invite me to do that, but we'll be in touch.
Awesome. Well, thank everybody for attending and being part. I've got some notes typed up. I'll send those out, and then yeah, I'll get everybody's contact info. You can send it to me on the same email that we organized this on, and I will provide that to Boomer.
Yeah, and do I have your? Yeah, I do have your number, Drew. Good. Okay, I want to get a hold of you. Okay, thanks again, all of you. Wow. I don't think the general public has any idea of the crisis that we're in a variety of areas. It's not just behavioral health, but that's definitely something we need to start with. So thanks again. Thank you very much.
Thank you.
Thank you for your time, everyone.
Yes, thank you for inviting me to this.
Sorry for your loss, Drew.
Yeah, it's going to be felt by the community. It was Johnny Waller.
Oh, I'm really sorry. Yeah.
Thank you very much for the time here and putting this together, Drew. We greatly appreciate it. And I think this was a really good first session.
I'm sure he'll be getting a hold of all of you.
Thanks, Drew.
Hope so. Thanks.